So my training is pretty traditional in the sense that I did open posterior-based surgery, open TLIFs. However, I wanted to migrate to more minimally invasive fashion of treating patients. My adoption first started with minimally invasive TLIF, but I always wanted to place a larger interbody cage. Lateral surgery makes a lot of sense, but I didn't want to deal with the flip and the positioning. So prone single position surgery just made a lot of sense to me once I started developing my technique around prone XLIF. The number one priority is to achieve the desired outcome. If that desired outcome is to use indirect decompression, place a larger interbody device, and be efficient in the manner in which you're delivering that care, then prone single position surgery will make sense for you. Because this is decreased anesthesia time for my patients, more of my patients in their 70s and 80s are getting this type of surgery. I've also had the ability to move my cases from a hospital to the ASC setting because of the efficiencies that we have. Performing prone single position surgery, and specifically XLIF, I use enabling technologies including neuromonitoring, specifically TMAPs, which gives me confidence that I can safely perform the procedure. There's a case of a patient who had pathology from L3 through S1, also a degenerative scoliosis, and then some foraminal stenosis causing leg pain. You can see from these pictures here that the patient has that degenerative scoliosis. The X-ray shows the curvature, which is mild, but what it's caused is some asymmetric disc space collapse. And we can see on the MRI in the next picture that's causing some stenosis on the right side at L3-4, bilaterally at L4-5, and L5-S1 on the left side. Now for me, as I approach this case, I need to think about decompression at all these segments. I got to think about restoring disc space height, decompressing indirectly, stabilizing the segments. I think about trying to accomplish this minimally invasively. There's other strategies that people may use, going anteriorly with an ALIF, but for me, this can all be accomplished from prone single position surgery. This is my plan. You can see that the XLIF was used at L4-5 and at L3-4. This allowed me to restore symmetry to the disc space and to provide an indirect decompression. At L5-S1, I performed a unilateral TLIF using minimally invasive technique, and then I placed my K-wires and my screws from L3 down to the pelvis in order to stabilize the segments in that position. Here you can see post-operative CT scans of what we accomplished. Good placement of screws and of the interbody device. And the final construct shows restoration of the coronal alignment, good lordosis from L3 through S1, and good disc space distraction, which allowed for indirect decompression. MASS TLIF 2 gives you the ability to perform open surgery through minimally invasive technique. The ability to hold interstitial distraction with the retractor blades gives you amazing visualization in the disc space, so that you can thoroughly clean, place bone graft, and then adequately fill with the interbody device. My interbody device of choice would be a TLX. You can expand the implant to 20 degrees of lordosis, which is substantial restoration when you're performing surgery at L5-S1 and L4-5. What differentiates Nuvasive is the ability to treat both degenerative and deformity pathology. I treat these in a minimally invasive way using prone single position surgery.